Hello, Dr. Manoj. Good evening.
Good evening, sir.
Good evening. Shivaji.
Yes.
Long time. Good. Nice to see you.
Nice to see you, sir. Thank you very much, sir.
Dr. Manoj, photo only is there. Is there? ശിവജിയാണത് കണ്ടക്ട് ചെയ്യണേ.
അല്ല, ഞാനല്ല സാർ. അയ്യോ,
ബിനു ആണ്, ബിനുക്കുട്ടനാണ്.
ബിനുക്കുട്ടൻ.
നിഹാസ് has come.
Good morning, sir. Good evening, sir.
Good evening. എങ്ങനെയുണ്ട്? ബിസി?
Sir. Usual, sir.
പിന്നെ ഡോക്ടർ സുമൻ റാവു കമ്മിങ് നോ അല്ലേ?
സാറേ,
ഡോക്ടർ സുമൻ
മാഡം ഇപ്പൊ ജോയിൻ ചെയ്യുന്നുണ്ടോ? ഞാനൊന്ന് വിളിച്ചോ.
അവസാനം 2 സ്ലൈഡ് കാണിക്കാൻ പറ്റുമോ?
ഓ സർ,
സമയം ഉണ്ടെങ്കിൽ.
ഓ ഷുവർ സർ.
അപ്പൊ ഷെയർ സ്ക്രീൻ തന്നെ യൂസ് ചെയ്താൽ മതിയോ?
മതി, സാറിനെ കൂടി കോ ഹോസ്റ്റ് ആക്കി വെച്ചേക്കാം, സാറിന് ചെയ്യാൻ പറ്റും.
ഓക്കെ, സമയം ഉണ്ടെങ്കിലേ ചെയ്യുന്നുണ്ടോ?
ഓ, സാറിന് പ്രീവിയസിലുള്ള
ഇത് ശരിക്കും സ്റ്റുഡൻസ് ആണ് അറ്റൻഡ് ചെയ്യേണ്ടത് അല്ലേ?
അതെ സാർ.
കുറച്ചുപേരെ വരുവുള്ളൂ.
ഇപ്പൊ ആർക്കും സമയമില്ല ഒന്നിനും.
ഇനി കോഫ് സിറപ്പ് ഇഷ്യൂ ഇസ് എ ബിഗ് തിങ്.
അതെ, ഒരു ജസ്റ്റ് നമ്മുടെ ഇടയിൽ മാത്രമല്ല, പേഷ്യൻസിനോട് ഇപ്പൊ ഓരോ പേഷ്യൻസും കോഫ് സിറപ്പ് എഴുതുമ്പോൾ നമ്മളത് സംസാരിക്കേണ്ട അവസ്ഥയായിട്ടുണ്ട്. എല്ലാവരും ചോദിക്കും
എഴുതരുത്, ജസ്റ്റ് കംപ്ലീറ്റ്ലി ഷട്ട് ഓഫ് കോഫ് സിറപ്പ്.
പോസിബിൾ അല്ലല്ലോ സർ. വി ചെയ്യുന്ന കുട്ടിക്ക് നമ്മൾ എപ്പോൾ നെബിലൈസേഷൻ അല്ലെങ്കിൽ MGS പറഞ്ഞാലും സമ്മതിക്കില്ല. നെബിലൈസേഷൻ വെച്ചിട്ട് എത്ര അയച്ചിട്ട് പറ്റും സർ? വീസിക്ക് ഉണ്ടാവും, എന്തായാലും കൊടുക്കട്ടെ.
ഹോട്ട് വാട്ടർ, സിപ്സ് ഓഫ് ഹോട്ട് വാട്ടർ, സ്റ്റീം ഇൻഹലേഷൻ, പഴയ പരിപാടികളിലോട്ട് പോട്ടെ. പണ്ടൊരു സാർ ഉണ്ടായിരുന്നല്ലോ, വെല്ലൂരിൽ നിന്ന് വന്നപ്പോൾ, ഐ ഫോർഗോട്ട് ഹിസ് നെയിം, കുര്യൻ തോമസ് അല്ല, another senior, he died sometime back. He was strongly against cough syrup. നമ്മളെ cough syrup എഴുതിയ ഒരു വിറപ്പിക്കും. Years back. ലാസ്റ്റില് സുമന്റെ ടോക്ക് കഴിഞ്ഞിട്ട് ഷെയർ സ്ക്രീനിൽ പോയാൽ മതി അല്ലേ?
മതി സർ.
1.5 minutes ഉണ്ട്. Hello, good evening. Dr. Suman Rao, good evening.
Good evening, sir. How are you?
Okay, seeing you after a long time.
Yes, sir.
So now I am too old to come for conferences.
Good evening, ma'am.
Good evening, everyone.
Good evening, madam.
Sir, you're never too old, sir. You're always inspiring.
Good evening.
Good
Ma'am,
evening.
I'm making you co-host, so you can share the screen also.
Okay, I will do that. I'll just open my slide. Can you see my screen?
Yes,
Yeah.
ma'am.
Yeah.
Yes, ma'am. Yes, ma'am.
Okay, fine.
Dr. Riaz has to come.
Yes, sir. Yes, sir. Will join.
Dr. Suman, you have a cough syrup issue? No.
I am so confused because we used to prescribe something Cineris, something and all. Now you're scared to prescribe anything.
Yeah. Well, how can we guarantee the product? Like,
Yeah, absolutely. That is so really. I don't know what stand as a group IAP is taking, what we are taking,
yeah,
but yes, I think we definitely need to take a stand.
true. Actually, today they showed in the paper the shed they were using for preparing this. It's a
Oh,
useless shed with tin sheets and all that.
yeah.
Very sad. Things are going sometimes bad.
Sir, actually, they also gave a blanket notice on not using all the type of cough syrup. They didn't specifically mention which one is safe, which one can be done, or something like that. Again, that is very confusing, sir.
And in Kerala, we have the Shabarimala issue.
Okay, I think now everybody has joined. We'll start. PMC, sir.
Okay. So,
Good evening, all. This is the second session of the talk series of the Presidential Action Plan of Dr. Joe, sir. It is very happy. We are happy to have Dr. Suman ma'am today to deliver this session. I welcome ma'am to this program. We also have our president, Dr. Joe, sir. I welcome sir to this program. Today's meeting will be presided by the IIP State President, Dr. Riaz. I welcome Dr. Riaz sir also to this program. And our first neonatologist in Kerala, Dr. PMC sir. Sir will be sharing this session and giving his insights about the sessions. So we welcome sir also to this program.
Thank you.
I want to tell two things before we go on to the presidential address. First is to thank the team who's working behind this to have such programs every now and then. Our state coordinator, Dr. Binesh and Dr. Lins, are behind this program. So we congratulate from the state OB for conducting this program without any flaws. So now I request Dr. Riaz sir, President IIP Kerala, to deliver the presidential address.
Thank you, Dr. Nihas. So this is yet another episode of the very important and useful activity by NNF Kerala, which is the Neonatology Talk Series. So because there are a lot of development in the field of neonatology, it is very important for all of us, including the pediatricians, to keep abreast with the new developments. And the topic for the day is also a very important one, that is feeding the preterms. And we have one of the most coveted faculty for the topic. Welcome Suman Madam to our midst. And to chair the meeting, we have the doyen of neonatology in our state, PMC Nair sir. So let us all learn together from all those great people here. And I offer my best wishes. And I take this opportunity to congratulate once again Binish and Lins for running this program in the best possible way. And I think the attendance in the program every time is very good. And we should continue the program without any hindrance. All the best, Josar and Nihas. Thank you.
Okay. Shall we start?
Thank you, sir. Now I request Dr. Binesh, the state coordinator, to introduce the speaker and the chairperson.
Good evening. It is my pleasure to introduce Professor Suman Rao, Professor and Head of Department of Neonatology at St. John's Medical College, Bangalore. She is also consultant with the Department of MCA, WHO. Dr. Suman Rao completed her MBBS from Bangalore Medical College, MD in Pediatrics from Madras Medical College, and DM in Neonatology from GS Medical College and KM Hospital. She serves as Director of the ICMR Collaborating Center of Excellence, Principal Investigator of ICMR Center of Advanced Research, and Treasurer of the IAP Neonatology Chapter. Her key areas of interest include kangaroo mother care, quality improvement, infection control, and perinatology. And she has more than 120 peer-reviewed papers and 30 book chapters in her credit. So we.
Muzaffarnagaril oru changai vannuണ്ടായിനി.
Sorry, somebody else. Please mute the other participants. Please mute themselves. And we are very privileged and happy to have you, ma'am. And over to you, ma'am, please.
Thank you very much. Thank you, Binesh.
Okay,
Thank you very much.
Can I just say one word for you? Good
Sir,
evening.
please, sir, please.
We have a golden speaker today to unravel the intricate mysteries of preterm nutrition. None other than my very good friend, Dr. Suman Rao. She is a professor and HOD in Neonatology, St. John's Hospital, Bangalore, and she requires no special introduction to Kerala pediatricians and neonatologists. Over the last 40-45 years of my neonatology life, I have witnessed so many changes happening in preterm enteral nutrition. Initially, in 1970 beginnings, you won't believe that preterm babies are given plain water, then 5% dextrose, then 10% dextrose, and finally 1:2 dilution cow's milk. Then re-emerged this golden era of breastfeeding, or BFHI, MBFHI, KMC, IKMC, and finally we are standing at the footsteps of mother newborn ICU. So Dr. Suman is a special WHO expert in KMC also. So we listen to her. Over to Dr. Suman Rao.
Thank you, sir.
One minute. Binish, somebody should be the host, and they should mute every other person who is speaking. The talk should not be interrupted. Thank you.
Yes, sir. Yes, sir.
Okay.
So thank you all. Thank you, Kerala NNF, for this honor. And it's indeed a privilege to be among friends again. Like PMC sir said, Kerala is very special because I keep coming there, and it is thanks to friends like PMC sir, Naveen, Manoj, who have given me this pleasure and honor many times. And thanks, Binesh. I wanted to say, tere muh mein ghee shakkar. I hope to reach 1,200 publications sometime. May not be in this lifetime, but thank you very much. And I humbly begin my presentation on preterm enteral nutrition. And yes, this is something I think is close to every neonatologist's heart, because what great surgeries you did is maybe a question that is asked to surgeons. But for neonatologists, one of the big questions is, what is the smallest baby who survived? How are they doing now? These are the things that we take pride in, and therefore feeding these preemies is something which is we do daily, but also some of the challenges that we face day in and day out. So thank you for this opportunity. And as we all know, like Sir said, we, the human species, called as mammals, this is all, the name is due to the breasts and breastfeeding. But at times, we find that the core issue of how the mammals survive, we forget. And therefore, we need to bring back the focus on breast milk and breastfeeding, even for our preemies. So today, over the next maybe 30 minutes, I'll be talking a bit on preterm milk, the guidelines that we have from the World Health Organization and also from our own NNF, then the beauty of mom, and finally, how to make it happen. So we all knew this, like Sir said. I think as far as term babies are concerned, we knew this forever, that breast milk is the best food. We also knew this, that it is species specific, but that it is baby specific. That means that the preterm milk is special for the preterm baby, and the beauty of it is being unraveled every day. In fact, in India, I think we have been ahead as far as preterm breast milk nutrition is concerned, but it was only in 2012 that the American Academy of Pediatrics first said that the best food for the preterm baby is the preterm breast milk. It was just about a decade ago. So we know that for the preterm baby, the human milk, the mother's own milk, is the best. But we also need to understand that the preterm milk is something much more than food. It's not only about nutrition. In fact, evolution-wise, the breast milk is more about immunology, about protection, rather than just about nutrition. And why do we say that the preterm milk is baby-specific? The preterm milk has much more protein, in fact, double the amount of protein, and also things like sodium, iron, vitamin A, which are so essential for the preterm baby, are much more in abundance. And, it's always great to say when we talk to families, we say, the mothers, you have a baby who is preterm, but God is great. God has given you preterm breast milk and made it very right. But it's very, very fascinating to understand the science behind it. As we know, when the preterm mother delivers, her breasts are still immature and the cells are not tightly bound. And therefore, between these cells, it's very leaky. And that's the result why sodium is higher. And also these proteins are so much higher. And as the breast matures and the cells become more better adhered to, the protein level sort of comes down. So it is fascinating to understand the science behind how the preterm milk is so special for the preterm baby. And what is more fascinating is that the smaller the baby is, the preterm breast milk of that mother has a higher protein for a longer time. So we should always attempt to make sure that the baby, preemie, gets his own mother's milk, and it will continue to have a higher amount of protein for a longer time. So this is a beautiful graph to show that the smaller the gestational age, the higher protein content remains longer. And then at the same time, we can actually engineer breast milk. We all talk about hind milk, of how hind milk has higher amount of fat and will help the baby grow. But this was one study which showed that when we use hind milk, we don't have to be worried about protein, because one concern was when you give too much hind milk, will the baby get deprived of protein? But this study had shown that the protein content remains the same. It's only the fat content which rises. And therefore, a small baby, when a baby drinks only around 200 ml of milk from his mother, the mother should still attempt to express the same amount, that's around 500 ml of milk, that she would otherwise produce for a term baby. And she can give only the hind milk to her baby to help make sure that the baby grows very well. Now, as we discuss, and this is something that everyone knows, but I just want to reassure, to remind ourselves that it's so much more than food. It's a live, actual, another person, I would say, because you don't not only have these nutrition component like protein, but you have higher amount of human milk oligosaccharides, immunoglobulins, lactoferrin, and actually, it's a live, dynamic, I would say, another person who is there to take care of the preterm baby. We always thought that preterm or any breast milk was sterile, but it's in the last maybe 15 years, we know that it's not sterile. It has probiotics like lactobacillus, which makes it so much more important. And even giving a small amount of breast milk to the baby and encouraging mothers who are struggling to produce milk would help the baby. For example, in a baby, when we use only preterm breast milk, some devastating conditions like NEC, sepsis, are all reduced. And if a mother is struggling, I usually use this kind of data to encourage them that even if you have 10% increase in breast milk on a daily basis, the mother is doing so much more to protect her baby from conditions like NEC. So encourage mothers to produce more and more, because even a little bit that they're giving will contribute to protecting the baby. And we all know this again, that it is the brain food. It has galactose, DHAs, amino acids like taurine, and even microRNAs. And this is another relatively new concept, that the preterm breast milk helps in creating the right kind of microbiome for the baby. And there is this gut microbiome brain axis. And this may be one of the reasons why neurodevelopment is definitely much better when a baby gets his own mother's milk. So this is, I think a lot of us have heard of this epiphage and lift cohort. This was way back, I think almost 2 decades ago, at the beginning of the millennium, where they looked at babies who were preemies in these 2 large cohorts and looked at the neurodevelopment. And this shows that how their mental or IQ was related to the type of feeding. So while we had the growth of the babies, which could have been smaller when they were on exclusive breast milk, the IQ of these babies at 5 years and others was much better. So this is called the apparent breastfeeding paradox, where despite the growth being a little lesser, the IQ and the brain growth is so much better. So for every increase of 10 ml per kg per day of human milk, the MDI and the other developmental scores were much better. Again, this is another slide which shows that what we do in the newborn period for these preemies has lifelong implications. So this is a cardiac morphology of the babies when they grow into adulthood. And here you see that the babies who are on exclusively human milk are very similar to the term baby compared to babies who are being exclusively on formula feeding. So for the preemie, like in the term baby, preterm milk is really protective, not only in the newborn period, but also lifelong. So that is why I like to talk about this. It's no longer a mother-baby diet, but we should think of the mother-baby breast milk triad. And we need to think of how both the mother and the preterm baby's milk helps in protecting this preemie. And we need to do everything to nurture this mother-baby breast milk triad. So we have these guidelines, both from WHO and NNF, which promote this. And now I'm going to go into the what, how, and of how to feed these preterm babies. So the choice of milk, very, very clear. Both the guidelines talk about mother's own milk. So it's not just human milk. We used to talk about human milk, but now we need to be more specific. Because when we say human milk, it could be mother's milk, it could be donor milk, or it could be commercial donor milk. So here we are talking about mother's own milk or mom, which is the recommended choice of milk for all preemies, including the ones who are very small. And when that is not available, then the next choice would be a donor human milk. And the third, of course, would be a formula. Now, there is a slight difference between NNFCPG and WHO. In WHO 2022 guidelines, which I was a part of, the third choice is nutrient-enriched preterm formula, whereas in NNFCPG, they talk about only a formula milk. So this is the choice, mom, then DHM, and then formula. What about fortification? And I'm not going to spend too much time on this. WHO is very clear that you don't routinely need to fortify mother's milk, but you could consider it when a baby is not gaining weight. And this is a conditional recommendation. So it gives a conditional recommendation for babies who are less than 32 weeks or less than 1.5. And whereas in NNFCPG, they consider giving fortification for babies less than 1,800 gram and starting it as early as 50 to 80 or ml per kg per day of feeds. But in resource limited conditions, they again recommend that it should be given for only those who have failed to gain weight. There's a lot on fortification that people are talking about, individual fortification, and protein, measure the protein content and then decide. But what is the true benefit of fortification is still a question mark. Yes, it does result in short-term gains in anthropometry and growth, but whether it makes a change in neurodevelopment and later on in life is still a question. But what is now being focused on is early initiation. The guidelines talk about as early as possible, start feeding the baby right from the word go. And in WHO, they're also concentrating on putting the smallest baby to the breast. So it's not about just feeding the baby. The baby should have an opportunity to suckle and lick at the mother's breast from the word go and should be fed express mother's milk as soon as possible. And in NNFCPG also, they talk about early trophic feeding and start with around 30 ml per kg and go on increasing it every day. And scheduled feeding is better than demand feeding for a preterm baby. Now, this is the current state of guidelines, but this is something new and India has been the leader in this. Early total enteral nutrition. The 2020 meta-analysis on this from Cochrane had all its five papers from India. And this has shown that you could consider early total enteral nutrition for all babies more than 28 to 30 weeks. And they did not find any difference in NEC. On the other hand, they showed benefit in lower sepsis and shorter duration of hospital stay. Of course, it is quite, it's easy to understand that time to reach full feeds will be shorter because they're already started on full feed, but there was also better weight gain. So in my unit, we use early total enteral nutrition if there's no other problem for babies who are more than 30 weeks and greater than 1,000 gram. Now, this was the evidence from India. But this is again an area where the world has followed India. And since 2020, there has been 4 other large trials in Canada and UK. And therefore, now the mantra is E3N or triple EN, that is early and exclusive enteral nutrition. Again, the results of these 3 large trials, ENACT, feed trial, have all shown that it is feasible and it is beneficial to start total enteral nutrition with breast milk for preemies as small as 28 weeks. But most of these studies did exclude babies who had abnormal Doppler studies. Now, these are the 2023 FPNC guidelines, which also follows this, that only for less than 28 weeks, as you see here, there is a recommendation of intravenous fluids. And this beautiful table gives also a guideline on what should be the mode of feeding. And here you see that even for a baby who is as small as 28 weeks, we should start off around breastfeeding by around 4 to 6 weeks, by 2 to 3 weeks in 28 to 32 weeks. So they do talk about Katori spoon feeding, but in South India, a lot of us use Paladay feeding, but we could also consider cup feeding. So how to feed the baby? We would rather use a cup, Paladay, a Katori spoon rather than a bottle. And that's very, very clear. Now, who do not accept it, then we consider tube feeding. And it is important to check the position before feeding. All these are sort of common sense. But what is again a very important recommendation is that we do not routinely look for pre-feed gastric residue, or nor do we routinely do abdominal circumference. When we stop doing this and do it only when we find there is a problem, we are able to reach full feeds much earlier. So there is this Cochrane meta-analysis which looked at this routine monitoring of gastric residuals. This was, if you see here, the Thomas 2018 that we have was a study done in our unit. It was an MSc nurses thesis. And when we did this we had some sort of guideline that we stopped doing pre-feed aspirate, but there was not much evidence to it when we started this study. And you know how difficult it is to convince nurses to give up something that they are doing. And therefore, in our unit, we did this randomized control trial mainly to convince ourselves and our nurses that it is safe to stop doing pre-feed aspirate. And to our surprise, we found that the time to full feeds was 3 days shorter in the group where we had stopped doing pre-feed aspirate. And the Cochrane meta-analysis again shows that very, very clearly. Now, a similar trial is being done, a very large trial in UK and Australia, which is still to be reported, called as the Neogastric trial. So again, a plea to our nurses that we stop doing routine monitoring because that will increase our feed intolerance. Supplementation is needed. WHO talks about iron, zinc, vitamin D, vitamin A. NNFCPG also talks about iron and vitamin D, but it does not really recommend DHA. Whatever we do, it is very, very sad to note that a large part of our proportion of our preemies land up with extrauterine growth restriction. The data I'm showing you now is unpublished data, but it is from a thesis from one of our DM residents who looked at a standardized feeding regimen that we are doing in our unit and then looked at body composition at term equivalent age. And we found that our EUGR incidence was almost more than 80%. And especially when we start looking at in terms of Z-scores rather than in terms of percentiles. And if you see here, even at term equivalent age, despite a very strong nutrition regimen, we do find the babies faltering on both weight, length, and head circumference. And when we looked at the body composition, what we found was that the fat content, percent fat, was almost double, and the fat-free mass was lower in the preterm at term equivalent age. So this is something that we need to remember, that whatever we are doing, we're still not there, and we are still not clear on the implications of this body composition later on both neurodevelopment or on adulthood. I think there are more studies which need to study body composition and its relationship. But what we definitely need to strive hard is to prevent EUGR. And these are two studies which have been published from India this year, which I would like to highlight. And one of them was looking at the amount of feeding rather than use the current weight, because the biggest contributor for EUGR is FGR babies. And in India, we have a big proportion of these FGR babies. And here you see that in this trial, the first one, a randomized controlled trial, which was done in Calcutta, they used the expected median weight for that particular gestation to guide on the feeding. And they found that their EUGR and the growth was much better. The second one is from Chennai, Uma and Prakash's group, who looked at early sodium supplementation to improve weight gain, and again a positive trial because hyponatremia is a very common condition. From CMC Vellore study, we know that we can even go up to around 300 ml per kg per day. And the best thing to do is to allow the preterm to feed at lib, take Paladay at lib, and not really restrict to the measured feeds that we always give. But very important is this. I mean, this is a color chart that I sort of try to use to remind ourselves, because whenever we get any aspirate, which is slightly altered, then we are all in a big rush to stop feeds. So if you see here, this milk and lemon color are normal, whereas even these other colors, which sometimes worries us, may be normal if everything else is okay. So this is one of the things that we need to remind ourselves as well as our nurses, that don't do pre-feed aspirate. And sometimes if you do and you find some altered color, don't be in a big rush to stop feeds. Then we come to a big problem of abnormal Doppler. Because this is another big problem that we face because FGR is so common. And people have been gnawing at the ADEPT protocol and trying to get the baby to get to full feeds earlier. We have bodies of work from Dr. Kanya's unit in PGI. We have work on the same which is being done from LTMC. So when we looked at these studies, even in our unit, we have been trying to look at how we can feed these babies in a very systematic manner, but without facing feed intolerance, and more importantly, NEC. So now studies have shown that we could consider feeding earlier, even in abnormal Doppler. So in our own unit, this is the protocol, which may be much more aggressive than other studies. And when we compared it with the published papers by Dr. Kanya, we found we were indeed a little more aggressive, that we start feeds on day one for even babies who have abnormal Doppler like reversal or absent diastolic flow. As long as there is no abdominal signs, bowel sounds are heard. And we start it as soon as they are born, and we increase it every 12 hours. It's only in the extremely preemie babies, like less than 600, that we are cautious in starting and start it a little later. So this is about abnormal Doppler, and I hope we have more studies which can show that we can safely start and escalate feeds. The other controversial area, which we still don't have a clear answer, and when we did the WHO recommendation, we had found only 2 studies, and based on that, we went with the recommendation which was there, that preterm or low birth weight infant should be exclusively breastfed until 6 months of age. The question was whether it should be 6 months of the chronological age, or it should be 6 months of corrected age. Definitely it is not earlier. We do not have any strong evidence to say it should be corrected age. So it is currently, the recommendation is that you should exclusively feed until 6 months of corrected age. And to facilitate exclusive human milk feeding, India has been quite a leader in establishing milk banks. And we have these lactation management centers in public hospitals and donor human milk, which has actually changed the scene. And donor human milk has become much more available. But I would like to introduce a word of caution when you have a human milk bank. Human milk bank should not undermine mom. When I say mom, mother's own milk, it is far superior to donor human milk. And though we don't have studies comparing donor human milk and mom head to head because it's not ethical, large observational studies have shown that mom is definitely much better. mom, the death is lesser, neurodevelopmental impairment is reduced, BPD, NEC, all of these things, the benefits are much more with mom as compared to DHM. The only thing that you see which is not very different is long-term growth. And again, when we look at body composition and neurodevelopment compared to mom, and here I'm not talking formula, I'm talking about DHM, mom is definitely better. There are studies to show that exclusive mom is better for BPD. And if you see this comparison of mom cohort and donor milk cohort, growth is better, feed intolerance is lesser, NEC, sepsis, severe BPD, death are all lower with mother's own milk. And then again, the real aim that we have, that is about neurodevelopment, that we found that for every 10 ml per kg increase in mom in an NICU, all the Bailey's developmental index points were far better. So why is mom different from DHM? Both are human milk. So why are we now splitting hairs and saying that mom is better? And first of all, the source. The source of DHM, particularly in these studies, are more from term babies. Processing has an effect, and there are inherent biological differences in the milk. So as we said, source of DHM is maybe chronologically later in lactation course, and the donated milk is produced in a separate microbiological environment. And here you see the difference between donor human milk and preterm milk, and you find that the content of protein is definitely lower in the donor milk. And when you pasteurize milk, many of these bioactive factors, particularly things like lactobacillus and all, and active cells die off. And we know that milk is dynamic, it's a living tissue, and all these cells are killed when we pasteurize milk. So mom is definitely different from DHM. And now there are ways of trying to look at how we can pasteurize milk without really affecting it and retaining its nutrition. And this is a slide to show how mom loses its, the different activities of the different enzymes are lower. And finally, each milk is unique. It is meant for that baby. The maternal genetics, the sex of the baby, the time that the mother is expressing, the mood that she is in, all that affects the kind of milk that she's producing. And therefore, whether it is formula, whether it is donor human milk, you will never ever be able to match mom. So that is why I would like to say, when you look at mom, you just invert the word, and therefore it's fascinating absolutely to understand the beauty of mother's own milk. And each time you open PubMed and look at preterm milk or breast milk, there's some other new article which tells us how precious, how beautiful it is. So I would like to say, mom is wow. And we need to understand this wow factor and do everything to ensure that the preterm milk is better. The baby gets it. But there are barriers to it. And as a neonatologist, I think everybody will agree with me. Every day on rounds, it's always about how much mother milk is there. Oh, it's only so much. How do we increase it? Because there are various barriers, whether it's maternal illnesses, because the smaller babies usually come out from a mother who is sick, and therefore she may not be in a condition to express, cesarean section, delay in skin to skin contact, separation at birth, because these are preemies who have problem. And we have seen that ELBW and IUGR infants are the ones who are most susceptible to low mom. And this is a study from I think, Telangana. So how can we make it happen? And in the next maybe 5 minutes, I would just like to remind ourselves 10 easy steps where we together can make mom happen very, very well. And the first is this. Like we have that every baby should get breast milk within the first 1 hour, we should apply the same rule to even our preemie. So early expression of milk within the first hour, frequent expression of milk. And in my unit, we document mother's milk output in our input-output chart of the baby as a vital sign so that we can track it. And you start expressing early and do it at least 8 times per day. And where even now we find that mothers on day 3, day 4, because they are sick, they haven't come, they say, how many times have you expressed milk? She'll say, oh, I've only started expressing milk now because it is now that I'm feeling the fullness and it's hurting. So this is a goal that we need to reinforce again and again, that even if the mother is separated, ensure that she's expressing milk herself or someone is doing it for her by just putting a pump on her, and she does it 8 times per day. And believe me, expression is an art. I saw this in Malawi as part of the IKMC trial. We had these old grandmothers who were breast milk supporters there, and they could get almost a full syringe of breast milk from the mom right there on the table. And that was what was being fed to the baby even before the baby was brought into the NICU. So even in my unit now, we try to express milk, not in a katori, not in a cup, because you'll never get so much, but take a 1 cc syringe and collect each precious drop, because like we all say, it is liquid gold, and then put it into the baby's mouth. And we should embrace technology. Breast pumps are beautiful, and we need to ensure that each mother has access to breast pump even if she's separated from the baby. And a lot of QIs have used breast pump, and there are companies which can even rent breast pumps for them. And NNFCPG also talks about using breast pumps for expressing milk. But very important is that we need to make the oxytocin reflex our friend. Because even if a mother has milk, if she's worried, stressed, in pain, it is like a tap which closes and you have less than 4% output even if she is having good milk. So she needs to be relaxed, and one good way of doing it is kangaroo mother care. Kangaroo mother care, the current recommendation is that you need to do 8 hours per day at least to have its effect on mortality. But for lactation, even a 30-minute skin-to-skin contact is enough to help her produce much more milk. So we need to ensure that baby gets kangaroo mother care, and that is where what Sir was talking about, that is the IKMC trial and the Transform Mother Newborn ICU comes into picture. So this landmark study was done in 5 countries, and that showed that mortality was reduced by 25%. When we looked at breastfeeding, we really did not find much difference in exclusive breastfeeding rates. But when we did a post hoc analysis, we did find that in the immediate KMC group, initiation of breast milk was earlier, infants were put to the breast before 72 hours, and they reached full breast milk feeds. Those who reached within 7 days were higher, and at discharge, those who were discharged on exclusive breast milk feeding was better. So definitely IKMC, even in centers which are doing good breastfeeding promotion, helps in improving the breastfeeding indicators. The next 4th mantra I would say again is making the mother relax and breast massage. Breast massage, just spending 5 minutes before she expresses through this massage, stroke and shake technique. In our study, again done by an MSc nurse, showed that the weight gain was better, the stool and urine output was better. So this is a simple intervention that we can do to make the mothers produce more milk. And again, it's a guideline that low-cost interventions like breast massage, breast warming, and relaxation technique should be used to enhance breast milk supply. And it's again a very strong recommendation. We need to give breastfeeding support to all mothers, but for the preterm moms, they need a special level of breastfeeding support. And therefore, BFHI has been modified as new BFHI for these. And we need to ensure that all the staff who are taking care of these babies are competent in providing the extra support that these mothers need. So skilled professional support is again something which is needed. But I feel that more than the nurses and health personnel supporting, it is the peer support which makes a big difference to the mothers. So it's always in our unit, we link one new mother with a mother who is more experienced, who is doing better breast milk production and KMC, so that she motivates the other one. This one is something that I learned through a QI, that elevate mom as a medicine. Our nurses are great in following it. And this was one QI where we had only one PDSA cycle. Our QI was to ensure that all children or all babies got colostrum, even if they were separated. And usually a QI goes through some 3 or 4 PDSA cycles before you attain your goal. But in this QI, we had only one first PDSA cycle where we just wrote it as an order in the medicine chart. And our nurses were fantastic in making sure that it was followed. So elevate mom as a medicine, and that will make wonders. And there are studies which have shown that applying this colostrum and mother's own milk has a lot of benefit, including in preventing sepsis and mortality. Non-nutritive sucking, something very, very easy to do, but hardly ever done. In my own unit, I struggle to ensure that NNS is done for all the preemie babies, but again, it's something that will help. I do use galactogogues, though we say that counseling is something and we shouldn't use galactogogues much, but try to look at natural galactogogues. But if that really doesn't work, even Domstal and all does definitely help in improving mother's milk. But what I really believe in is that in every unit, there should be some ongoing QI to improve breast milk, not only for the preemies, but also for the term babies. So quality improvement is something that has been shown time and again to improve the mom's availability for babies across various NICUs in our country. And I would urge all those who are struggling to ensure mom is available for their babies to take up a QI and do it. And these are QIs from different parts of the country. So in conclusion, I would like to say that enteral nutrition of a preemie is very, very simple. It is just 3 letters. Mom, mother's own milk. We have to make it happen. It is the best. It is a living, dynamic protector of the preterm infant. So you can think of a preemie as having 2 guardian angels. One is the actual mom, and the other is the mother's own milk. And we need to protect both. And by 10 steps, we can optimize the availability of mom for the preterm infant. So thank you very much for your patient hearing. And back to you, sir.
Okay, thank you, Dr. Suman Rao. We are really impressed. Every time I hear your talk, I learn something and I'm really impressed. So thank you very much for the accelerating and mind-opening or provoking talk. And so before we go into the discussions, can I have just 2 minutes, Dr. Nihas? Because
Yes, sir. Please, sir.
will it open like that? No.
So just share your screen, sir.
It's only one participant. That may be the reason I cannot play it.
No, now only you are the sir. Other one is already.
Okay, that's just summing up what Dr. Suman Rao has said. 10 commandments in preterm enteral nutrition, because I thought a lot of pediatricians are also there. As Dr. Suman said, mom is the first choice anyway, mother's own milk. Express breast milk via orogastric, a cup and spoon or per day. And only if these things are not available, you go for the pasteurized donor human milk, which of course Dr. Suman Rao said, which has got a lot of insufficiencies and deficiencies. And continuous feeding is not recommended because lipase are lost. Intermittent orogastric bolus feeds are the best. Third point commandment is minimal enteral feeds. You start with 10 to 15 ml per kg per day and slowly increase. 10 to 15 ml for a 1 kilo baby, it will be less than 1 ml. And feeds should be started as soon as the baby is hemodynamically stable within the first 24 hours of life. And this SGA babies, Dr. Soma clearly explained. We had a journal club meeting also on this. Absent or reverse end-diastolic flow of umbilical artery, still with the baby stable, can be started with EBM as early as 6 hours of life. Kanya was my student in PGI. She published this in Journal of Pediatrics 2025. And full feeds 150 to 170 ml, less than 1000 grams. By 2 weeks, you should be trying to reach full feeds, but most often we feed less than about 1000 to 1500 grams about 7 days. And the frequency of feeds, weight, if it is less than 1000 to 50, feed 2 hourly, because there are a lot of confusion among many units. And if it is more than 1,050 feet 3 hourly, this is based on a lot of Canadian studies and Saurabh Datta's, etc. Then the other good thing is, as ma'am also said, in the absence of other signs of feed intolerance, there is no need for routine occult blood testing in stools, no need for routine abdominal girth measurement, no need for gastric aspirate checking before every feed. We were doing these things painfully earlier on, and gastric residual volume also, if it is small, no need to look for it. If gastric residual volume is more than 50% consistently, blood or bile in the gastric aspirate or features of obstruction or abdominal distension more than 2 centimeters, then only stop feeds. The nutritional supplements, as ma'am said, human milk fortifier, and the NNF says less than 1,800 grams and receiving enteral fees of at least 50 to 80 ml per kg per day. These supplements is very important for the postgraduates. They should remember these values: calcium, phosphorus till 40 weeks, multivitamins, the vitamin D till 1 year, elemental iron starting from 2 to 4 weeks, 2 to 4 milligram per kg per day till 1 year. Probiotics, again, the questions I will be asking you after this. Multi-strain probiotics in preterm babies have been suggested in units with high incidence of NAC. And in Australia, some other units are continuously giving these probiotics. Probiotics significantly reduce the risk of all-cause mortality, late onset sepsis, and NEC. Multiple strains are found to be having greater effectiveness in reducing mortality. And 9 commandment is no unnecessary medications, erythromycin not to be used, no need for gastric acid suppressants like domperidone, H2 blockers, ranitidine, proton pump inhibitors, etc. We are using Rantac earlier, left and right. And the last important point is growth velocity monitoring, mainly the weight, length, and head circumference. And growth, if 20 to 30 grams per day weight gain, 1 centimeter length increase, and 0.9 centimeters head circumference increase, then you are happy. So to conclude, this is Dr. Suman Rao. Newborn ICU, we have here the KMC, IKMC have been started, and now the MN ICU, Mother Newborn ICU, started in Bangalore, St. John's Hospital. Dr. Suman Rao doing the examination of the baby, and the mother is confidently looking at the doctor. Thank you very much for holding on. And now we are open for questions. And especially we want to learn something more from Suman Rao regarding MN ICU.
Thank you, sir. I was just trying to answer the questions in the chat. Some of them I have, but to answer Dr. Akash's question, I really don't have a clear evidence-based answer, Dr. Akash. I personally try to use a lot of hind milk, but usually it is hardly ever that we use only hind milk. There are people who say you have to mix milk and make sure that baby gets both fore milk and hind milk. And the best way to answer this would be to actually have studies and look at long-term outcomes, not only growth. Growth would improve when you give only hind milk because it has more calories, but also about body composition, neurodevelopment. Now, as far as MNICU is concerned, thank you, sir. That's definitely my pet topic. And MNICU is a place where both mothers and babies are taken care of right from the word go, where there is zero separation that we do for the term babies, for even the preemies. And in the IKMC trial, it was mainly for level 2 care, that for CPAP and so. So in our own unit also, we have a 7-bedded MNICU and we do CPAP there. For babies who are on inotropes or on invasive ventilation, currently they are kept in the main ICU. But we do KMC even in the main ICU, even for the small babies, but the mothers are sitting next to them. The big benefits of MNICU is that it is not only has benefits for the baby, but also the mother. Studies have shown that postpartum depression, mother's empowerment is much better. The long-term neurodevelopmental studies are still to come, but short-term, like use of antibiotics, we are currently doing IKMC implementation research in a district in Karnataka. And what we are finding that the quality of care indicators like use of IV fluids, use of antibiotics, over time, as the IKMC coverage increases, these things are definitely improving. So MNICU, I would think that it is not only about KMC, but it's about improving the entire quality of care, because you have the mother who is a 24/7 monitor for the baby, and who also ensures that everybody else around the baby, like the nurses and doctors, follow infection control practices. We empower her to tell us that if somebody is not doing hand hygiene well, that you have the power to stop anyone touching your baby if hand hygiene is not done well. Yes, we have to balance this, because initially when we started, we had a lot of conflict between nurses and mothers, and we had to do like focus group discussions to ensure that we were all on the same page. But now I think we are in a good balance where mothers and nurses understand that our common goal is improving the outcomes of the babies, and it has definitely much more tangible benefits than just about neonatal mortality, breast milk, and other uses.
But did you require more support staff in the infrastructure?
So more than support staff, we definitely require more space. Like in a unit where you could put around 14 babies, now you can put only around 7 or even lesser, because the mother's beds take up. As far as staff is concerned, not so much, but we also need to allow one more relative to come in because the mother needs it. And in the MNICU currently, we don't have the system of caring for a sick mother. So it's only a well mother who comes in, and therefore her needs are quite limited, and most of the time they are taken care of by the relative, and the nurses are only giving medicines and maybe small things for the mother. So the support staff from the nurses is not really more.
Okay, thank you. Any other questions? Incidents of NAC stage 2 or more in your unit?
Yeah, we still struggle with it, Dr. Sargent. NEC, I'm difficult for me to give incidents as such, but we still struggle with NEC. It is still a dreaded word in our unit. And we are doing our best. We use probiotics, we use all this, we have a good QI program, but NEC is still a problem.
Okay. And any bugs isolated in this group?
Currently, we are struggling with Acinetobacter and E. coli MDR bugs. And it's more of what is there in the community, because sometimes we find these bugs even on day one. And it's quite a struggle, because then we need to cohort them. So this year we have been having mainly Acinetobacter and E. coli.
Okay. So enteral nutrition has always been going on, having changes.
Definitely, because that way you are restricting the number of pricks. Sometimes we're not even having an IV line. We are not putting central lines, and therefore the lesser we do, I think the outcomes are better.
Yeah, definitely. Vinesh, any questions from the audience? Because we have right before us a person with experience, and
I
that
guess almost all the questions to chat box has been taken.
A couple of questions in the chat box. What's the latest consensus on probiotics for NEC?
As far as the WHO guideline is concerned, this in fact I can share with you the inside story. The WHO this in 2022 has come out with a conditional recommendation on probiotics, that for babies who are less than 32 weeks, do consider it. And in fact, when we had this in the guideline development group, it created quite a furor. Because if you see the Cochrane meta-analysis, it's sitting on the wall. It shows evidence that it is beneficial, but if you read the end, they say, no, we are not sure whether we need to really give. But the evidence for probiotics is so strong, whether it is NEC, whether it is mortality, whether it is sepsis. And we cannot ignore that evidence. And therefore, WHO came up with a recommendation that you should consider probiotics. The guideline development group said, give us more information, because currently there's no clear guideline on what probiotic to use. So we remember talking to Dr. Jeeva, he quickly did a network meta-analysis, and unfortunately, we still don't have a clear guideline on which probiotic is concerned. Maybe a combination would be better, but WHO is clear that it should be a conditional recommendation for these babies. If you listen to the Australian group, clearly they talk about probiotics. If you listen to the US group, there is this FDA, there are some, case reports which actually put people on the back foot and they don't use it. But for us, we are using probiotics and we continue to do it. We stop probiotics when the babies get discharged from the hospital, but there's a large trial which is going on, which is looking at using probiotics even after they get discharged. And they're also looking at nutritional outcomes like growth and all, and in relation to probiotics. So there is going to be much more information we'll get in the next 2-3 years because there are large trials which are ongoing on a global level.
Okay. I think India is the best place to do this study because it's cheaper and quality control has to be there. That is the main problem. I have always been a probiotic man from the beginning. So in Australia, so many people are doing it now. Sanjay Vaser and another Dr. Sanjay, he is using it in the Australia hospital. We had been to Kim's recently.
And the other question again related to probiotic is that which is the probiotic that you use in your unit, if you are using it, and once you start it, when are you going to stop the probiotic?
I don't think we have a great choice of probiotics. We have used Darolac in our study and we continue to use that. We did a study 10 years ago to look at probiotics and feed tolerance. It was a negative study. We did not find that it reduces feed intolerance. But there was a trend towards reducing NEC. So since then, even before these guidelines have come out, we are using that. We use one sachet per day for all babies till they are discharged. And there's other question on 80 ml per kg. I guess, Dr. Vimal, you're talking about whether we start with 80 ml per kg on day 1 for 30-weeker AGA baby as full enteral nutrition. Yes, we do that. And we have now the luxury of a milk bank, which way we can use donor human milk. If you look at Dr. Shushma Nangya's articles, they have actually done this enteral nutrition even with formula. But we don't have the guts to do that and we don't use formula. So when we start early total enteral nutrition, mom is usually very difficult to get 80 ml per kg on day 1. So we rely on donor human milk.
Okay. I think there are no more questions.
The one thing which I love to be in the middle of Kerala group is that there are a lot of our students who are from Kerala and it's always a pleasure to interact with them. So thank you very much.
Thank you. Thank you for taking up this assignment also today. You must be busy back home.
Dr. Akash has a lot of questions. Okay, Akash, we collect it with a 1 cc syringe and every drop we suck it out into it. That is how we get colostrum, and we either give it to the baby right there in the labor room or the baby has to come in with that syringe into the NICU. Otherwise, there's no entry for the resident who is bringing the baby. Okay.
Okay, Nihas.
Okay, ma'am. Thank you. Thank you for a great session on enteral nutrition. All of us enjoyed the session and had a great learning with you. Thank you, sir, for being present today and sharing the session and sharing your own experiences. Now I request Dr. Lins to deliver the formal vote of thanks.
Everyone. So that was a really enlightening session from Suman ma'am. Actually, this topic is something very important. Like, I think I personally know many level 2 NICs, they even now keep the extreme preterms NPO even on day 1, day 2. So I think this session was really enlightening regarding the importance of
Your
starting
hospital course was given 2 times.
So it was actually really enlightening session regarding the importance of breastfeeding. So also the early initiation and rapid advancement of feeding and reaching full feeds as early as possible. Thank you, ma'am. Thank you for that enlightening session. Thank you, BMC sir, for presiding the session.
Okay,
And thank you, our state president, Riyaz sir, Nikas, Dr. Binesh, and all the seniors and my dear colleagues for joining this session. And we will be continuing this session in the next month also. Hoping to meet you all again. Thank you. Thank you all. The meeting will be.
Thank you, Dr. Suman.
Thank you.
Thank you.
Thank
Thank
you all.
you
Thank you
all.
all. Good night. Good night.
Good night, everybody. Okay, bye.